and well-known surgeon from all over India as a challenger in this session. So we'll proceed to the program. Dr. Shogoto, would you please share your screen for introductory speakers introductory slides. So this is a very popular format of challenging case symposium. It's very popular in ACRS and ECRS also. And Dr. Gaurav also started same format in AIOC, All India Conference, which has been very popular last 2 years. I think it started just 2 years back, 2 to 3 years back. So today's session, Dr. Rotish Pal is a founder, secretary of Sushrutai Foundation and Research Center, and he is currently vice president of West Bengal Ophthalmological Society. He's the chair of the session. Next slide, please. And it is my great pleasure to introduce you, Dr. Suyash Holdipurkar. He do not need any kind of introduction to this part of India, at least. He's a teacher for last more than 3 decades from who are doing the cataract surgery. He is a founder member of Lakshmi Eye Institute Tertiary Eye Care Center in Palwel, Navi Mumbai, founder and chief trustee of Lakshmi Trustable Trust, medical director of Lakshmi Eye Bank, and director Lakshmi College Optometry and running BSc and diploma course in optometry and paramedical training. Recognized Center for the Post-Graduation in Ophthalmology and Surgical Training. Earliest practitioner, he is the first person who started phaco institution in India, teaching faculty at Winter Academy in Australia for last 20 years, and awarded with Certificate Educator Award by APCRS 2018. And known for his surgical technique and presentation all over the world. This is very, he's a recipient of C.S. Reshmi Award and many more awards all over from India as well as abroad. Welcome, Dr. Suyash Holdipurkar, as he address the keynote address in this session, and his topic will be discussed. We'll introduce it later. Next, we'll like to introduce our juries in this session. Dr. Rajapal, please.
Thank you, Arup. I have the honor and privilege to welcome Dr. Ramamurthy, the distinguished panelist, erudite, soft-spoken gentleman, all the way from Coimbatore. He completed his MBBS from Gibson Condistory and alumnus of RP Center with his post-graduation, and also from Shankarachalaya. At present, he is the chairman of the Eye Foundation, the state of art. I don't know how many hospitals now here, might be in 1,300 for the hospital situated in
the volume a little louder, Ajay, a little louder, I think, volume.
His area of interest is in cutting-edge technology in cataract and refractive surgery. He was the chairman, scientific committee, AIOS, for a period of 6 years, the past president of the same organization. He has been awarded 21 named orations in India and abroad. He has been invited speaker and has performed live surgeries in most parts of India and several international zones. He has 21 publications in peer-reviewed journal. He has been conferred Asia Pacific Certified Educator and is spotted distinguished on the Teachers' Day to have him here, awarded by APSCRS, APO, and Distinguished Service Award from the American Academy of Ophthalmology. Yes, can I move to the next distinguished?
Yeah, good evening. It's my great pleasure to welcome our own Dr. Partho Biswas. He's the director of BBI Foundation, Kolkata, and currently all of us know he's currently serving as the chairman, scientific committee of All India Ophthalmological Society from 2020. He has also served as the chairman of Academic Research Committee of AIOS in 2 successive sessions, 2014 to 17, and then again from 2017 to 2019. We'll have to arrange a webinar to discuss what awards Dr. Biswas has received. But in short, he has received almost all awards available in India, He has received Corneal Rangachari Award, AIOSC on 2011, ES Series Video Award, APS Series Video Award, both in 2013. Then oration, he has given several oration, such as Vidarbha Ophthalmological Society oration, then Orissa State Ophthalmological Society oration in 2017, R.C. Meher oration, Daljit Singh oration, and Mrs. T. Agarwal Gold Medal oration, to name a few. He has also received Hanumanta Reddy Award in 62nd AIOC, then as the Best Paper Award in 2011, then BOA Gold Medal Award, Indian Intraocular Refractive Society Gold Medal Award in 2007, 2015, and also received all the awards available in Ophthalmological Society of West Bengal, such as BK Mitra Award, BK Mitra Award, then Satyarani Hazra Award, then Kiyat Datta Award, and also received award DK Bose Gold Medal in 1991 and the Hussain Gold Medal as well. He is serving as reviewer of ophthalmology, International Journal of Ophthalmology, seminars in ophthalmology, and also IOVS and Sudan Medical Journal. He has several publications under his name, and also he is acting as a postgraduate teacher and evaluator of AIOS, and also guide for DNB guest faculty in national and international conference. We all know him for his court-martial in ophthalmology. He has done over 75 sessions of this famous program, ophthalmic program. Welcome, Parthoda. Welcome, Dr. Partho Biswas, sir.
And it's my great pleasure to introduce Dr. Gaurav Bhutra. He's a cataract and refractive surgeon par excellence, and he is one of the teacher for technique and technology of cataract and refractive surgery in India, and he is a medical director at Drishti Eye Institute, Dehradun. He has a special interest in refractive and challenging pediatric cataract surgery and as well as keratoconus. He has been served chairman academic and past president of Intraocular Implant Refractive Society of India. Over 200 live surgery demonstration and 5 oration and 4 named national award. Welcome, Dr. Gaurav.
Thanks.
Yeah, among the speakers, we have Dr. Minu Martin. I think he'll be presenting his video. And he is graduated from Trivandrum Medical College in 1996, did DNB from Arvind Eye Hospital, Madurai in 2000, worked at Arvind as a teacher, training and overseeing the microsurgical training for residents and trained them both from India and abroad in ECC, SICF and PECO, published several papers in peer-reviewed journals, presented many papers and videos, and was a chief instructor and co-instructor at state level, national and international conferences, ASCRS, PSCRS, APSCRS, APO, and AIOS. Won the best paper, best poster, and the best video awards at ASCRS, APSCRS, PSCRS, and AO meeting. Has received APO Achievement Award, and presently is the consultant and medical in cataract and refractive lens surgery service at Chaitanya Eye Hospital and Research Institute, Trivandrum. Yes. Welcome, Dr. Minu. And we have Dr. Harshal too, who graduated from Dr. SN Medical College in 1998, did MS and from SMS Medical College, Jaipur, Rajasthan, with gold medal. He coined the term hydroimplantation in ophthalmology and published the technique in hydroimplantation in JCRS in March 2010 and cataract refractive surgery today Europe in October 2010. And thank you, Harshul, for making us follow this technique, and it's given wonderful results. He has been the office bearer of various prestigious bodies like Rajasthan Ophthalmic Society, AIOS, and IIRS. He's been the assistant editor of IGO Cataract Section, chief organizing secretary of Leukopenia Annual Conference of GSI 2017. Awards and recognition. We got the Surya Narayan Gold Medal for the best video film in ROS 2010, best paper session in APS CRS in 2014, special gold medal at IRS 2015, and best cataract and video in IRS 2015.
It's my great pleasure to introduce Dr. Deepak Megur. I think I am a fan of Deepak, of his surgery and the recording of the surgery as well. He is the head, the cataract and glaucoma department at Megurai Center, Bidar, Karnataka, India, specialized in the complex and cataract surgery, committed in sharing and teaching surgical skill. And he has a YouTube channel. I follow his YouTube channel for the phaco training. And I want to inform the junior surgeon who want to learn surgery. It's the fantastic quality of the surgery in the phaco training is YouTube channel. He's a CSRSME award in 2020. Is the best paper in cataract in AOC 2018. And he best paper and cataract video in KOCSC in 2019, and numerous award. He got numerous awards from in all over India. Welcome, Dr. Deepak. And it's my great pleasure also introduce my dear friend Love Kochugay, and he become the pediatric to now become the powerful adult surgeon, and MBBS from the Bangalore Medical College and MS from Patna. And currently he's the director of Netra and BBI Foundation in VIP Kolkata. It is grand prize winner in APCRS and best video award with OSWB and KAO. And publication, he has more than 15 peer-reviewed national, international journals. Welcome, Dr. Law.
It's my great pleasure to welcome Dr. Ashwin of Agarwal. He's a cataract, cornea, and refractive surgeon with special focus towards handling complex and challenging cases at Dr. Agarwal's Eye Hospital in Chennai. He holds the position of Chief of Clinical Services and is associated with ISRS AAO One Network and in many ways. His online web series of world webinar on cataract and refractive surgery and rising stars in ophthalmology are something to look out for. And he actually mesmerizes everyone with complicated surgery. It looks very simple when he does a complicated surgery. Welcome, Ashwin. It's my great pleasure to welcome Dr. Devashes Dutta as well. He has done his MBBS from NRS Kolkata and MS from Berhampur, Odisha. He has done his fellowship in medical retina at SN Chennai and has received several awards in ASCRS, OSWB, and IZOG, and has publications and acting as a reviewer in national and international journal. He enjoyed complicated surgery, and again, looking at his surgery, it looks simple when he does complicated surgery. Welcome, Devashish. Dr. Siddhartha Ghosh, welcome to this webinar. He is a consultant ophthalmologist currently at GD Hospital and Diabetic Institute of Kolkata, Apollo Medical Center, Kolkata, and Nightingale Hospital, Kolkata. He's a very high volume cataract surgeon, and everyone knows him in OSWB as a very smiling and helpful doctor. Welcome, Siddhartha.
Now I welcome Dr. Suhash to deliver his keynote address.
Yeah. Thank you so much, Arup. It's indeed am I visible?
Yes, sir.
And audible as well. Yeah, thank you so much. Thank you so much again for this opportunity to be with you. I really love the crowd that you have gathered together, all the great people in Indian ophthalmology today. Managing expectations, aberrations, and decentration is a topic I'm going to talk. We all know today the management of cataract surgery has more or less matured.
Sir, sorry to interrupt you, sir. If you can go full screen.
Full screen.
Okay.
Yeah, thank you, sir.
Yeah. Today, managing cataract anatomically is more or less a matured process. What we really need to focus on is on the physiological outcome of cataract surgery. With this, let's go to the next. Let's talk about various aberrations that we get. The corneal irregularities due to corneal scars and archaic cuts can cause image distortion, pupil decentrations, lens colobomas, IOL tilt, and IOL decentrations are another few causes of that cause aberrations, and all these are higher order aberrations which cannot be corrected with spectacles, and they require sometimes, if possible, some special treatment. If you look at centered and decentered pupil, with a centered pupil, it's always easy to cut off all the peripheral lights in a dynamic state of the pupil and to get a very focused kind of a image, which is not possible with virtually impossible with a decentered pupil. And that's the reason, if you have a decentered pupil, which can be surgically corrected, that will be the first attempt anybody should try, because finally it's the patient's satisfaction that we're really looking at. Talking about IOL decentrations, mostly it is inherent zonular weakness or history of trauma that can cause the back to decenter at some stage after the surgery. There'll be many more other surgically related steps that might lead to IOL decentration later on. But finally, if you have one, then you really need to take care of it. Now, this is a case which I did 12 years back. A child around 13 years old came with a trauma, and the vitreous was bloodstained and present in the anterior chamber. With the available technology that I had at that time, I tried to manage it. If you notice, there's a huge traumatic mydriasis, which I really couldn't manage. At that time, the prevailing thing was Sion's ring. I used Sion's ring to manage it. But since pupilloplasty was still not a very mature technique in those days, I couldn't do it. But subsequently, when he came during his follow-ups, I realized that he had a choroidal tear near the macula and his vision was not improving. But in every visit, I tried to tell him that why not we do pupilloplasty, because by then pupilloplasty was in practice. But he always refused it because he never had an issue with glare. But his vision was not improving, which I was trying to relate to his scar that I was seeing near the macula. And then one day recently, he comes back with sudden drop in the vision. And what has happened is a Tenno suture that I used in those days to fix the Sion's ring had snapped, and the entire back had subluxated anteriorly with a severe amount of tilt. Now, the tilt was causing him all the issue. There were different ways I could have managed it. You can also see the posterior capsulotomy because it was a child and I had to do Yak capsulotomy at a later date. So the best option I thought here was to go and use the same Sion's ring and this time use a Nino suture to fix it. And to my surprise, the entire lens back complex shifted back to its normal place. And something that I always wanted to do, and I had advised him, and here was a chance for me to do pupilloplasty for him. And with pupilloplasty, I was in for a surprise because post-op, after 2 weeks, his vision improved to 6/9 partial, which I never really expected because I was always thinking his vision was not improving because of his macula that was not healthy. Over the years, his macular appearance had improved, but what was causing him the problem was a lot of glare that was, coming in the way of his visual satisfaction. Now, here is a case which, I operated 3 years back. He comes after 3 years with a history of his grandson hitting on his eye, and the back lens complex, subluxates, comes anteriorly. And in that particular portion, entire zonular structure is lost. But because it is only 3 years old, I know there's a way I can fix the back. I tried to separate the rhexis from the lens, but it is difficult. So I go with a 26 number needle and try to create a space, although it is firmly stuck there. And with little space, I use some viscoelastic to push in and create a space. And after that, using 2 hooks, I stabilize the bag. And this time, I decide to use a SCR anchor to fix the bag. And SCR anchor is like a paper clip, which you can easily clip into the rexis edge and fix it, and the bag would very nicely get fixed there. And once it is done, you take your hooks out, and post-op, even the intraoperative, the pupil constricts well over it, because unlike with the MS segment, since it is in one plane, iris doesn't have any issue sliding over it. So he got back his normal vision, whatever vision he had post-op. This was a third case of coloboma, the congenital coloboma in both eyes. He presented recently with drop in the vision in both eyes. His vision was 1 meter and 3 meters. It was improving to around 660 and 624. And that was probably his vision for a long time. He just came for a checkup to maybe change his glasses, or because this 20 was never given to him. I offered him treatment. And so first thing I did was to do his eye trace. And I was surprised, and as all of us would be, and we would expect partly, his cornea had hardly any higher order aberrations, and the internal aberrations were full of trefoil and coma. And this patient undergoes surgery. The surgery was uneventful. There was nothing special about this surgery, except that, because he was 28-year-old, the nucleus was soft. Surgery-wise, there were no challenges here, except that at the end of cortical aspiration, I had to use internal, capsular tension ring. And after that, the lens was placed. It's just that, in such small bags, it's sometimes difficult to place both the ring and the lens. And after that, the surgery there's nothing much to talk about the surgery. Post-op, his vision improved. And as expected, if you look at the eye trace results, his pre-op higher order aberrations had completely cleared. His MTF had improved drastically. Even his Snellen E letter also showed a significant improvement. Now, these are some of the things you can do. Now, this was a case I did several years back. That time, eye trace wasn't there. The history was child, when I did, the child was around 17 or 18 years old. But as a child, in her childhood, she had a trauma for which she was operated, and a large chunk of iris tissue was taken off. And after that, over the years, what has happened is she has developed a lot of lenticular aberrations, and her vision had drastically gone down. Unfortunately, over the years, in a span of 10 years, this traumatic lens coloboma had also developed. So the capsular bag had also shrunk, and the aberrations had, the higher order aberrations had suddenly increased. Here again, the issue was not managing the cataract. That was okay because the nucleus was soft. But what was important was, after the lens is placed in, how am I going to do pupilloplasty? Because so much of tissue is lost here. But unless you create a pupil, it is difficult to get a quality vision. So here, what I decided to go through the side port and cut at the root of the iris to advance some amount of iris tissue, which I did on both the sides. And with that, at least I could get a circular pupil, but rest of the portion just continued to remain defective and open. But it didn't really bother her because she was used to, because glare was never her problem. By getting this pupil in the center, I was hoping to get some semblance of a pupil. And with that, if I can improve the vision should. And as expected, her vision went to 612. And I was very satisfied with that because it was pre-operatively much poorer. I do not have eye trace things because this was done quite some time back. And then I come to this picture because all of us are very much used to seeing people coming 10 or 15 years after the RK that was done so very unethically at some places with multiple scars on the cornea. This significant irregular corneal astigmatism leads to ocular aberrations, which can only be negated by reducing the pupillary aperture. And when we come to the pinhole effect, which has been popularized now, it's an optical concept suggesting that smaller the pupil size, less is the defocus from spherical aberrations. And when light passes through a small pinhole or a pupil, all unfocused rays are blocked. And Dr. Amar has popularized pinhole pupiloplasty, and he explains in detail how angle kappa or chord length can be reduced to get an effect. So he has consistently shown excellent visual improvement in post-RK and AK cases. Here I have a case which has undergone RK followed by AK, followed by LASIK, followed by cataract, and followed by LRI. Everything led to this kind of a picture, and his vision is now from 6.6 that he had maybe some 20 years back to around 2 meters and not improving. Now here is this patient who undergoes pinhole pupiloplasty, and now we have all of us have seen excellent pinhole pupiloplasty shown by Dr. Amar. This is one of my case where to get the visual axis in the center, sometimes you may even have to use a cutter. So this is the post-op picture where his vision from 2 meters has improved to uncorrected 636 and with best corrected around 680. And that was something the patient was extremely happy about. So in conclusion, patient satisfaction can be greatly enhanced by paying attention to all the doable measures using modern diagnostic and therapeutic measures at our disposal. And that is what all of us should try, because visual focus should be on physiological regaining of good quality vision. Thank you so much.
Thank you, sir, for a wonderful speech regarding the centration, aberration, and visual expectation of this type of patient. I just hand over this mic to Dr. Bhutra to carry forward the discussion regarding these cases.
Thanks, Arup, and it was really spellbinding to see Haldipurkar sir's videos and those tremendous, results with some of these rescue techniques that sir has used. So I think the pinhole pupiloplasty is frankly, something which Dr. Amar has described, and we could probably never imagine that this can give such kinds of results with, some of these patients who have highly aberrated corneas, and where you can create, a very pinpoint kind of a very small pupil. Although there have been people who have raised a lot of concerns about, the amount of light passing through and some of the problems that may face, but patients do, they kind of give us such fantastic visual improvements and quality treatments that it is worth trying. And of course it's a reversible technique, so it can always be enlarged if you need to. And some of the refixation, and with the number of cases that we are currently seeing with over the years that we've been doing scleral fixations and the glued IOLs and the CTRs which have been sutured and the Sionese rings which have been sutured, we are bound to see patients who are going to come to us with capsular back complex, capsular back complex dislocations and situations where they will need these kind of surgical interventions. So I think the innovations are phenomenal, and we can all innovate, and there are so many ways to refixate these things. And sir, of course, is a brilliant surgeon, and he's elegantly shown very, very nice ways to very easily, he makes it look very easy how you can actually do these. So I think with that, I would like to pass it back to Arup to put in a few more comments from somebody else.
I just want a few comments from Dr. Ramamurthy, and Juiz, you can ask question to Dr. Subhash.
I think fantastic surgery. Initially, thank you so much, OSWB, for this wonderful invitation. Indeed, an honor to be a part of this elite panel. And fantastic surgery, Suhas. Nothing less was expected of you. And I think he has driven home the point that if it's the lens which is defective, then the lens has to come out. He showed those high amount of lenticular aberrations, and removal of the lens. Obviously, it's a dysfunctional lens, so it improves vision. And again, basically the eye which had about a -20 diopter power, once you replace it with an intraocular lens, the magnification effect of the minus power glasses goes away, and you have a lens right next to the nodal point. So obviously there is an improvement in the visual acuity that's expected. And when you make a pinhole pupil in a case of highly aberrated cornea, because the light rays are passing through the visual axis, then again there is bound to be an improvement in vision. But the question I have in mind is Suhas's initial cases where there was a large pupillary defect, a coloboma of the iris, and where he said that the patient was refusing to get treated, and incidentally fixed the coloboma, then subsequently the vision improved. That is something I'm a little surprising to me, simply because obviously he would have poor quality of vision. He might have had glare, halos, difficulties in the quality of vision, but so making the pupil smaller would have helped him. But as far as the quantity of vision is concerned, there was lens present in the visual axis. Rays of light were getting focused onto the macula. How do you explain that just doing when the lens was reasonably well centered before the patient had the trauma? How do you explain that just refixating and making the pupil smaller improve the visual acuity so significantly for this patient? Just a doubt. Otherwise,
Ramu, there's some mix-up in your thing. I'm talking about, I was repeatedly asking the patient to get his pupilloplasty done was a first case, which was a traumatic, subluxation, where his vision was not improving. And because I was seeing the macular scar there, so I thought probably that's a reason. But his pupil is so widely dilated. But after 12 years, when he comes with subluxation of that iris lens bag, lens complex, which came anteriorly, it had to be sutured back. So at that time, when I sutured his pupil, I created his pupil as well. His vision improved. So it's partly because of the pupil, partly because over the years, his vision did improve. And the case that you're talking about is a lens coloboma, where that was the first time that patient came to me. I never advised him anything before. He came for defective vision. That defective vision was partly because there was a huge lens coloboma and there was an iris defect as well. That lens coloboma was taken care with, lens. So dysfunctional lens was taken care. And because there was a huge defect, I tried to create a pupil. Whether that creating pupil has helped him or no, I do not know. But his vision, improved because the dysfunctional lens was replaced by intraocular lens.
Oh, I agree with all your cases, Suhas. I mean, my query was only about your first case. I mean, it's more to have a discussion in the sense that, what you also referred to just now, whether you had fixated the pupil, fixated the lens. At that time, you did not do a pupilloplasty because that was not popular at that point of time.
Yes.
And the patient had poor vision. I mean,
Yes.
which you thought is because of a macular problem. Subsequently, you you had to do a second surgery, you made the pupil smaller and more elegantly, more elegant. But how did the vision improve in this case? All along, the patient had intraocular lens, which was reasonably well centered. Patient obviously had an abnormal pupil, a large iris defect, but light was passing through there was no corneal abnormality in this particular case.
Okay. I'll explain. See, over the 12 years, every time he came, I did see his vision improving. From 6/18 part, it kept improving because I could see his macula. The macula was also improving over the time. First, when I saw, I thought this macula is, because of a choroidal scar there, probably he won't get. But his vision was over there improving. So the last time I saw him, he had gone to 6/12 and it stopped there. And after that, after 2 years, he came with this snapping of NO. At that time, I fixed the same lens, but additional thing was making the pupil small. Probably I thought making that pupil small might have added a line or more. He came to 6/9 part.
Great. Fantastic surgery, Suhas. I mean, I really appreciate what you did.
But can I have a word, Arup?
Yes.
Yeah,
Yes.
Pat.
So the first and foremost thing, Arup and OSWB, thanks for having this webinar on Teachers' Day. And I have to tell everyone, and I must tell how much we have learned from Dr. Suhas Haldipurkar. Sir taught me capsulorhexis, and till date, every surgery of mine, I am indebted to him. Thank you, sir. One question again, as the bad student, I will ask you, sir. Our retina colleagues always have this difficulty about the visualization for a pinhole pupiloplasty. So, and especially with these high myopic eyes or a traumatic eye. So the pinhole pupiloplasty is a challenge for the retinal evaluation. I've asked this question to Amar also, and same question I asked to you, sir. So how do you think we justify to our retina colleagues?
Yeah, now today with machines like Optos or any of these non-Vitriotic fundus cameras, even with a small pupil, you can fairly get a good view from, ora serrata to ora serrata. So that means if you really find it difficult, you can. But in fact, this question I have asked Amar as well when he makes it really, really small. But the answer he gave me was, if it's truly difficult, I would always maybe, use YAG laser to just cut it or make slight opening and see the fundus. Yeah, that's a downside.
Partha, there was this IOL which was, in one of the film festivals that I was judging, there's a unique IOL which has been described, which, allows this pinhole effect, but it also allows, viewing of the fundus because of the special, wavelength of light that it, uses, so that during surgery or for fundus imaging, you will get a full pupil, but for visualization, you'll get the pinhole effect. So I think that would answer all the things.
Gaurav, you are right, absolutely. That's the innovation from Brazil. There's a pinhole effect of the IOL. You have to put the IOL in the sulcus. You have under the iris, like you put the implant ICL or IPCL. It's a pinhole effect, but you can see the fundus as well with the bright illumination. Thank you. We can proceed for next speaker.
Arup, I just have a question for Dr. Haldipurkar, sir. Just a practical tip. When you are doing pupilloplasty as a surgeon, to get the plastic thing right in the center, using the microscope light reflex, or getting how far away from, especially if you have a coloboma, quite a big coloboma. As you've shown, in that case, you have just slipped the iris to get it more area. So any practical tips as a surgeon?
No, you're talking about the traumatic case where a lot of iris...
Not in this case, in general, to getting the pinhole pupiloplasty, to get that the opening right in the center.
Well, it's trial and error. Like you take one suture below, then maybe you won't take one exactly opposite. You may take it on side. See, you keep doing it till such time. You do it under topical. You can always ask the patient to look at the light. And then, sometimes when you take a suture, you feel that by taking one suture, the iris has come over the visual axis. You can always either cut it or go with the cutter and create a small opening there and take another suture. It's like a trial and error you do. Eventually, you want your visual axis to be in the center of the pupil.
Exactly, sir. It is not possible to make a absolutely central. You have to use vitrectomy cutter to make a absolutely. You look for the parking image.
Yes.
Try to make it, but sometimes people iris tissue come into the center, and you have to cut accordingly to make a central round small red seal. Yes. So we can proceed to.
Can I just make one?
Thank you, sir.
Can I just make one observation for the purpose of the listeners? So that was masterful surgery from Suhas. Not every one of us can do it, but whenever you have a highly abrated cornea, before doing any surgery, please try scleral contact lenses. You'd be amazed at the kind of results that some of these lenses give. So that even without any surgical procedure, you might be able to get away.
Thank you, sir. So may we now welcome Dr. Siddhartha Ghosh to present his talk, Trouble CME Challenge.
Well, thank you. Thank you, SWB, for this invite. Good evening, everyone. And in the next few minutes, we are going to discuss about CME challenge. Before the real hardcore challenging surgical cases come in, let us discuss where are we today on cystoid macular edema. Well, if we look at the evolution of cataract surgery, we all know that cataract surgery is one of the most common procedures performed worldwide, and it is also one of the oldest, but it had a phenomenal evolution through the years. And if we see the treatment landscape of cataract surgery in India vis-a-vis the population of India, the prevalence of cataract above 50 years in our country is about 48%. And 7% of these eyes undergo cataract surgery every year. That is a huge phenomenal number. It's more than 8 million every year. Now, we also understand that ocular symptoms after cataract surgery may influence the patient's assessment of overall treatment outcome and quality of life. For example, in this case, where uneventful cataract surgery by phacoemulsification and implantation of IL was done, and the next post-op day, when the vision was checked, he had had a very good vision. It was better than 6/9 unaided. But this patient, when he reports 4 weeks later, his vision dropped to 6/8 in best corrected. And that made us look for what could be the reason. And lo and behold, we found this. So cystoid macular edema is something we need to be very aware of and be careful and alert about. If we look at the incidence of CME, it's about 2% in uncomplicated cataract surgeries, but it could be as high as 55% of eyes in pre-existing diabetic retinopathies in India. Now, the inflammation that is due to the surgical manipulations causes breakdown of blood-retinal barrier, and that is the major cause of cystoid macular edema. Angiographic Cme is more common than clinical Cme, but fortunately, angiographic Cme is mostly asymptomatic. These patients can present as acute CMEs, that is CME occurring within 4 months of surgery. It could be late onset after 4 months of surgery. It could be chronic, the CMEs which last for more than 6 months, and they may sometimes present as recurrent cases where the CME comes on and off with time. And most of these patients would come with decrease in visual acuity, loss of contrast sensitivity, and metamorphopsia. And clinically, we can only detect the CME if the central foveal thickness is more than 300 microns. But then we need to be alert about the vitritis if it is present or if there is any optic nerve head swelling. And let us remember that the mean age or the mean age of onset or main period of onset of CME after cataract surgery is about 4 to 12 weeks, but it peaks at 4 to 6 weeks. We need to identify the risk factors for CME, which is crucial for prevention and adequate treatment. So amongst the systemic risk factors, diabetes and hypertension are the most important ones. And other than them, the RVOs, glaucoma, uveitis, VR interface disorders are certain pre-existing ocular conditions which are risk factors for CME. And for today's discussion context, very important intraoperative complications like PCRs, vitreous loss, incarcerated vitreous in the incision, cortical remnants in the vitreous or trauma to iris, and sometimes even iris fixation or ACIOLs may lead to CMEs. Diabetes being one of the most important risk factors for development of CME, and it has been shown that the incidence of CME in patients with diabetes can be as high as 2.4 times more than what it is in the normal population. Now, diagnosis of CME is clinical as well as with the help of imaging techniques. Fundus fluorescent image angiography is a very ideal way to document CME, but it's invasive. So OCT is the most commonly used tool for both diagnosis, follow-up, as well as prognostication. Autofluorescence is yet another simple, non-invasive technique to document CMEs. As for the management of CME, the most important step is prophylaxis. And some of these patients who has developed postoperative CME may require pars plana vitrectomy if they need surgery. And of course, the medical treatment, the mainstay are corticosteroids, NSAIDs, carbonic anhydrase inhibitors, and sometimes anti-VEGFs as well. As for the prophylaxis to prevent CME, we need to remember that non-steroidal anti-inflammatory drugs are and the corticosteroids are the first line agent for prevention of postoperative CME. And if we look at these publications, amongst all the currently available NSAIDs, nebafenec, amphenec has the broadest coverage, and the amphenec has the strongest, COX-2 inhibition amongst the commonly available NSAIDs. So the current practical challenges in India are compliance, patient compliance, standardized treatment protocols, and the availability. Well, we need to optimize treatment, optimize the number of drugs, but we also need to be minimalistic to ensure adherence. Thank you.
Thank you, Dr. Ghosh, for your excellent insight on not only the causative factors of CME, but also why we should treat CME or why we should prevent CME. Because in our premier cataract surgery practice, patient with little less vision, they can make your life hell. So prevention is probably better than cure in this situation. So I'll hand over to the jury, Dr. Ramamurthy, Dr. Partho Biswas, and others, if they want to grill Dr. Ghosh for a few minutes. Dr. Ramamurthy, sir.
Well, I mean, supposing, very nice presentations, Siddharth. And just in case one eye has had CME and the second eye is presenting for, say, uncomplicated surgery in the first eye, and the second eye is coming in for surgery, are there any special precautions you'll take? I mean, you said it all, but you obviously, the second eye also has predisposition. Anything?
Absolutely, sir. Absolutely. That's a very interesting and very practical question. Actually, in all these cases, who had, like patient who has suffered, had CME in the past in one eye, the other eye, we tend to treat them with NSAIDs for a longer period, maybe 2 to 3 months, and very stringent follow-up. And of course, we need to look for the risk factors that that might be there, that might have been overlooked in the first surgery. But using NSAIDs as a prophylactic before surgery and prolonged usage after surgery can take care of this situation.
And sometimes if, there is uveitis and in the eye is quietened down and subsequently developed, your thoughts on putting in an intravitreal steroid implant, because that gives you a slow release over a period of 3-4 months, that also significantly reduces the incidence of CME and other recrudescence of inflammation.
Absolutely, sir. Especially in those recurrent cases, like patients who had uveitis in the past, we want them to be wanting to have a quiet eye for at least 3 months before we plan for surgery. And of course, we can use this intravitreal dexamethasone implants, which takes care for a longer period. They are wonderful.
Okay. Dr. Ghosh, we know in diabetic patients, they have 10% chance of having diabetic macular edema, even if they don't have macular edema prior to surgery. And at the same time, they have chances to develop CME as well, cystoid macular edema. So for the sake of the listener, if you can just highlight how you can differentiate between diabetic macular edema and cystoid macular edema.
Yeah, it's more theoretical. First thing is, many of, if you, by history, if you see that how long the diabetes has been in this patient, how long he has been a diabetic, and the more prone he is to have diabetic macular edema as such. But for cystoid macular edema, sometimes if it is a classical pseudophakic CME, then you can really make out through a fundus fluorescein angiogram. The typical CME features are there, as well as the staining of the optic disc would be there. So that is one thing. And some OCT features are also very prominent. In diabetics, you may expect to get, other than cystoid macular edema, if it is also a diabetic macular edema, you may expect to get, when there is a lot of, because the cause is inflammatory here, predominantly inflammatory, you may get a subretinal fluid in the OCT. That can also differentiate between the two. And of course, if you have hard exudates and other features of Diabetic retinopathy, there is no doubt that it's a mixed feature. So one can be sure that.
We can move to next speaker. Our next speaker is Dr. Ashwin. Dr. Ashwin, can you please share your screen? And his topic is My Fair Lady.
Hi, folks. Thank you so much, West Bengal Society, for having me. Honestly, it's such an honor to be with these stalwarts who I've learned so much from. And Dr. Suhas, that was an absolutely fabulous presentation. Thank you so much for that. It gives so much depth into that topic of precision that we all need to strive towards. The topic that I'm going to be talking about is My Fair Lady. I do have financial interest with LISR, but none of it pertains to my talk today. I am going to be talking about My Fair Lady, basically the white lens and white cataract, but I'm not going to be showing you the cases that you routinely probably do, and also give you a small few tips here and there which really help in real time in surgery. So the first case that I wanted to show is this of what I do in these white cataracts, especially when you're doing a small incision case. But the peculiarity here is that there is a very, very, very shallow chamber, pretty much no chamber. If you saw, I was touching the iris there, and there's no space to even inject viscoelastic. It was that shallow. And you'll notice that I'm making paracentesis incisions to put in an iris hook. But also look at the iris popping out through that incision, owing to the fact that there is a very, very tight chamber there. I'm making a very small rhexis first to basically reduce that intralenticular pressure, which is what is my technique of choice. Post which I expand or extend that incision or that rhexis with a spiral rhexis. I like to get rhexis in these cases rather than using a can opener technique. For a couple of reasons. One is if I'm implanting a premium lens, I definitely like to do that, number one. Second is also what I've seen is over the years, if you leave this with can opener type of openings, the iris kind of gets attached to that capsule, and it starts looking like a not so pretty pupil. And you can see here that after I've reduced the intralenticular pressure, I've got a little bit of space to kind of dial my nucleus into the anterior chamber and hopefully bring it out without any struggle. And once this is done, I've got a lot more space now. Obviously, I have to still do my irrigation aspiration. And post that, I'm able to implant a lens. In this case, I did implant a 3-piece lens. But ideally, you can go ahead and because your rhexis is round and you can implant anything, you can even implant a premium lens. And that's one of the biggest advantages of doing this double rhexis technique, which basically owes to the fact that your rhexis won't run out if you're going to make a small rhexis and reduce that intralenticular pressure. That is the first case. The second case is one of a Morgagnian one. If you can see here, it's a very clear-cut Morgagnian cataract. You can see the brown tinge of the nucleus down below. But the fact over here is what you have to understand is you can't actually notice the density. You can see that, yes, it's a brown cataract, but how big is it? Is it a large one, small one? So you go ahead with I have gone ahead with the phacoemulsification. And once you puncture this bag, you'll start seeing the size of this nucleus. And also what you start noticing is that the bag is not a healthy bag, which is also noted by the milkiness of that, the crystalline milkiness of that, this thing. You can see the zonules being dragged all the way along. Now, a couple of things here is that you will be challenged with visualization, and that is because you will not be able to visualize so easily. So what I started to do is use a double technique. So basically you bimanual technique, but I'm using one hand to hold the rest of the bag. But that's not enough. I know that this bag eventually will go in for a zonular weakness over the years, if not during my surgery, because I'm a little more gentle on these on this tissue. So what I started to do in these cases is basically ensure that I have a nice deep chamber there first and start making my flaps. The bag being so elastic and so unhealthy does not warrant me to keep the lens inside that bag for a long period of time. And so what I started to do in these cases is place a trocar AC maintainer, make my scleral flaps and my sclerotomies to do a glued intraocular lens under this nucleus. And the reason that I started to do this is it's also called as glued IOL scaffold. So I'm doing a glued intraocular lens, but using the glued IOL as a scaffold so I can do my emulsification on top of this. But that's conceptual. Now I'm trying to do this practically. So there's a little bit of visualization challenge, but the visualization that you really need is only the tip of the haptic. So you really don't need to see the whole optic go in. There's no bag that it's going in. Once you see that you grab the tip of the haptic, you can bring it out. And now you have a full-fledged protective layer below. Again, you do tuck them in, but that's not the end of it. And I'll tell you why, because you still have to go ahead. And just in interest of time, I'm going to, go through with this emulsification. But watch what happens. And this is what the trick is. You have to visualize the haptics at the end because the second haptic had dislodged while doing the emulsification because the pressure component might have been a little bit more from the saline or by my hand. And you can always retrieve that second haptic by first, by a bimanual technique, as I showed you over here. And once that's done, you can actually just glue that flaps and haptics back in place. This is the second one. And do I have time for 1 minute? I think this is a 1 minute video only. This is a sombering ring. And I know this is not a white cataract, but it's still cosmetically not so pleasant for the eye, number one, and it's an aphakic patient. So I really need to put a lens in this eye, scleral fixated lens. So I am going with the glued intraocular lens technique, but here's a tip and trick that everybody should know. I always tend to remove this sombering ring, and I know it's not easy. Number one, because you can see that rim anteriorly, which is fully phymosed, and the capsule has completely closed down, clamped down on it. So the sombering ring is all around. The reason I remove it is because I really want to make sure that there is no tilt post-operatively. So I'm actually going ahead and doing my glued intraocular lens first. Once my glued intraocular lens happens, my pupil shuts down. So what I start to do is first visualize what's happening all around. Now I know that there is sombering ring everywhere. Now quadrant by quadrant, I'm basically, after my tucking, obviously I'm finishing my tucks. Now quadrant by quadrant, I'm going and ensuring that I'm able to pull out these pieces. Now these pieces do not come out with cutter so easily. In fact, you'll be sitting there for 45 minutes and you'll be still cutting. So two techniques. One is this burp technique, which basically repress the posterior lip of the wound and try and bring these pieces out. Angle them in an axis so that it really pops out easily. But even if you try those in smaller pieces, they might work very well. And I'm always ensuring that I'm removing this this remnants of the bag vitrectomy. Here's the big chunky piece here will not come out through a burp technique. So you probably need a phacoemulsification, which takes it down in less than 30 seconds. Once that is done, quadrant by quadrant, you can ensure that you don't see the optical edge of that optic. To close that off, I'm also doing a pupilloplasty. Otherwise, what happens is you will have an optic capture or of that optic. And this is the pre-op, post-op of this patient. These are some of the white my fair ladies that I wanted to show you. And thank you so much for having me. I definitely want to have some questions if there are.
Thank you, Dr. Ashwin, for showing us such difficult techniques. Now, coming to your second case, before I hand over the mic to the juries. In the second case, you had an intact PC. So what was the use of putting the IOL, scleral fixation IOL with so much of difficulty under the hiding nucleus and then emulsifying the nucleus? You could have easily done the phacoemulsification when the intact PC is there, and then you could have taken the
hand over your mic to jury. It's a jury's job to.
Okay.
I think that's a fair question.
Dr. Ramamurthy, sir.
Oh, I think that was a very excellent question. Maybe Ashwin could answer it, but I think Ashwin brought out an excellent point in the sense that we're in a stage of transition. in the sense that, there was so many presentations about scleral fixation, iris clip lenses, I mean, about the way to fix the bag, the capsular tension segment, capsular tension Sionis rings, endocapsular rings, etc. But now the concept is, I at least have started believing it. If it's an unhealthy bag, it's not, you may get it stabilized on the table, but that's not the way it's going to stay for the rest of the life of the patient. So I've also started shifting to this concept that if it's a dangling lens, I mean, instead of spending hours on trying to fix it, take the lens out in toto, and whatever you are comfortable with, whether it's Yamane technique or glued IOL or iris clip lenses, that lasts much longer, and the lenses are fairly well centered. I believe that Ashwin, Amar, and their group have brought out this concept very well, and there are more and more adherents to this. I think now you can take up that question that was asked, Ashwin, and maybe answer that.
So I think your point is exactly what I was going to say, Doc. I think the point we're moving to a phase where what's happening is we really need to understand what the patient really is going to be benefited with the most over the years. I do not want to do a second surgery on a patient. I don't want to take them up. I've seen too many of these patients where they come back after 5 years or maybe 10, between these two, 5 or 10 years, and that lens is either dangling or there is some vitreous coming from somewhere. And if you saw when I was doing my rexes, it was pulling the zonules fully. I mean, it was not a light pull of the zonule. It was a complete pull of the zonule. It looked intact, but it's a very weak and unhealthy bag. The one trick I'll tell everybody to watch out for is if you poke that bag and you see crystally white milk, those shiny white crystals when they come out of that milk, it's a clear sign that that bag is not going to last for long. And because I've seen when I've done these cases earlier, and I see these patients 5 years later, all of them have some kind of tilt, dangle, or something like that on him. And then they complain saying that you did it. You need to correct that. I can correct this in one shot. I know it's a progressive approach, but I think it really will transcend over a period of time.
Ashwin, I was concerned about one thing. It was like a really, really challenging case, especially that Morgagnian one. But just like your that one haptic kind of dislocated, and if it had allowed some of these nucleus fragments to go behind, without your realizing that it's kind of dislocated, that could be one scary thought. So I was thinking that before kind of removing the PC, you could have maybe just used the IOL scaffold as such with the PC left behind, and finished off the nucleus so that. And then gone and kind of removed the PC and fixated that same 3-piece lens, to the using the glued thing. I'm not sure. I mean, it was
just a scare
for me. Yeah,
you've hit the nail on the head. And so what I've started to do nowadays is not to do the vitrectomy part initially. I actually do the glued intraocular lens a little supracapsular, above the capsule. I would leave that capsule. I would do the glued IOL above the capsule. If I don't need to do a vitrectomy, I'm going to try and avoid a vitrectomy. That's where I've moved also towards. And I've shown this in my previous surgeries. In this particular white cataract, I didn't have a video of that, but I've already moved over to that kind of performing the surgery in the sulcus space. So you do the glued intraocular lens in the sulcus space without actually doing a vitrectomy. That's the thought process which I'm working with right now.
Very nicely done. Yeah.
Thank you.
So I think, Ashwin, IRSI is in December as a physical conference.
Yes, absolutely.
And Court Martial is there.
Absolutely.
And you are there as my surgeon, and I'm saving my questions for that day.
Okay, done, Doc. I'm going to have Dr. Ramamurthy protect me there. Don't worry.
And Chitra, of course.
My one other addition is, more for the sake of the listeners, in the sense that when you did a scaffold with a hard nucleus in the anterior chamber, I would feel that whatever be your excellence in phaco and dispersive viscoelastics, maybe doing a SACS would be a good idea to bring out a large nucleus like that, rather than doing a phaco technique.
Absolutely well taken point. Yes.
Thank you, sir, for the comment. Arup, if there is no other question,
But I do urge everybody to move on to the double rhexis technique whenever they have a chance, because that is something that has really been exceptionally changed the way that I perform all of these. Whether I'm doing phaco or I'm doing small incision, it doesn't really matter. Do the double rhexis, make a very tiny rhexis, just let that fluid come out, and then do the spiral.
Dr. Ashwin, the rhexis can run out even after the first nick. So you might, sometime you might not even get the chance of doing the small rhexis, and it can run out.
No, I agree.
So I actually do a different technique, but for lack of time, I'm sure many of us do with a inverted 26G needle, just puncture and draw some fluid out to decentralize the pressure in the center, and then do a double rhexis technique. Because even after puncturing and taking some fluid out from the center, you have higher interlenticular pressure in the periphery. So you can do a small rhexis then, and then decompress the periphery and do a bigger rhexis. Probably that is, it takes a bit longer time, but
the time doesn't matter in these cases. Honestly speaking, time doesn't matter. The end of the surgery, patient has to win.
Yeah.
Thank you, guys.
Arup, you are on mute. You have to unmute yourself.
Arup.
Dr. Ajada, we can.
Yeah, I think we have our next speaker, Dr. Minu. Is he here?
Dr. Harshul. Dr. Next speaker is.
I think Dr. Harshul will be presenting. Yes.
Okay.
Yes, please, Dr. Harshul.
Good evening, everybody. At the outset, I'd like to thank entire OSWB for this kind invitation, and thanks Dr. Arupda, Dr. Ajay, Dr. Parthoda, everybody. So I'll be sharing a case. This case was, can you see my screen, Arupda?
Yes, it's visible, okay, very well.
Visible. So this was a white cataract, and there was a history of some trauma as well. And the problem was that this capsule was also fibrotic. So as you can see, this entire 5mm or 6mm area is very fibrotic. So it was really difficult to initiate the capsulorhexis. So I decide to start from this area where I can see that the capsule is not that much fibrotic. So I make a small nick here with cystitome and use the microcapsulorhexis forceps to start capsulorhexis. And you can see the subluxation is also almost 5 to 6 clock hours. So I initiate capsulorhexis, changing my hands. And once I reach this area where there is a lot of fibrosis, don't try to continue using forceps because it may extend the tear in periphery then and there. So always use scissors to cut through this fibrotic area, and use the scissors through different ports so that you can cut it nicely. So even if you have to make one additional side port, don't hesitate in making that. So using the bimanual approach, I hold the leading capsulorhexis edge with the micro forceps and cut it with the micro scissors. So now the capsulorhexis part is done, and here I go and put viscoat, and is a time to stabilize the capsular bag to give some anteroposterior support before we start phacoemulsification. So these are the capsular hooks which goes in the capsular bag, and they support this entire capsular bag complex. So once you stabilize the capsular bag, then go ahead and do the chopping. So I go ahead and make a first chop. This was a brittle kind of white cataract. Turn my phaco probe on other side and take a piece of the cake. And so once this nucleus is out, you need to stabilize the capsular bag with CTR ring and or a Cione ring you can use. So here I decide, and nowadays I always prefer to use CTS because it's easier to implant also. So after taking out the entire nucleus, I go ahead and put OVD through side port to maintain the capsular bag. Put OVD from side port and come out. Now the work of this capsular hooks is over, so if you want, you can take off these capsular hooks before putting CTR ring. So I take them off, and then I thread the CTR ring through side port incision. So here the CTR ring, it goes. Either you can use the injector or the freehand technique, and it's always a good idea to stabilize it with the second instrument while putting the second eyelet. So once the CTR ring goes, it stabilizes the capsular bag equatorially, and then I had already made a scleral groove 1.5 or 2 millimeter behind. So take off this cortical matter, clean the capsular bag. And once you clean this capsular bag, I use a 90 proline suture and put this CTS segment. So these two eyelets, they go in the capsular bag, this curved area, and the hook which is coming out, it remains above the anterior capsular access margin. And then you can use 26 gauge needle or 30 gauge needle to railroad the proline sutures which you have already tied. So here goes the I railroad the first suture, one arm of the suture. So once both the arms are taken out, you can see that it gives the good stability and centration to the capsular bag. So nowadays, instead of proline, we have also started using Vortex Sutures, which is non-degradable and gives a longer stability than 90 proline.
So little bit fast forward to your case, please.
Yes, yeah, it's almost done. Yeah. So once we stabilize this capsular bag, I go ahead and put an IOL in the capsular bag. And hydro stitch all the incision. So that's it. Thank you so much.
Thank you, Harshul. I think that was a wonderful, the stuff, especially the capsular access part, the bimanual way of doing it. We have got some of the experts here, both, all the three of them are quite, depth in doing all these sort of cases. But then whether that Rexis, while doing it any other way of, for a beginner or for somebody who's a mid-level, I think I'd go to the jury. And the long-term stability, as we had the earlier speaker saying, that long-term stability where I suppose 90 has worked wonders. Is Vortex available or any other way of doing it? Yes, I go to the jury. First go to Dr. Ramamurthy, followed by Dr. Partha and Dr. Gaurav.
Superb surgery, Harshul. I mean, couldn't have done anything better. But since I have to comment, I mean, this is one of the situations where femtosecond laser would be great help in the sense that you won't get a free floating Rexis, but you would get an excellent template. And of course, you managed it very well manually, but getting the Rexis would have been made much easier, especially for not as an expert surgeon as you are. A couple of things I might have done differently is one is I might have put some maybe you did it dispersive viscoelastic in the area where the
I put it.
So that the anterior vitreous space was somewhat protected. That would have been the first step I would have done. And I think it is a great tip in the sense that you put both the endocapsular ring as well as a CTS inside. And nowadays we have largely given up a Sionis ring, and it's extremely important to combine both these because the endocapsular ring gives you circumferential support of whatever zonules are there. And the CTS actually tethers the capsula back to the sclera. But again, it depends upon the type of cataract. If it is a traumatic cataract, if I find that it's nicely expands and seems to be stable, since the zonulopathy is not progressive, I might not have even gone in with a CTS. But if it's something like a pseudo exfoliation or a Marfan's, where the zonulopathy is progressive, it's extremely important that you tether it again to the sclera. And another thing is, maybe this was a few years old video. Nowadays, we believe that even though you are going in with a 3-piece lens, to offer further stability to the capsular bag, you can put the haptics in the bag, but create an optic capture. In the sense that rather put the optics in the bag and have the haptics in the sulcus, and that's supposed to offer additional stability as far as the bag and the lens is concerned. And as we already discussed, maybe in these difficult cases, if you're not as an expert surgeon as Harshal, maybe it's even a good idea to remove the lens in toto and go for a secondary IOL.
Yes, Partha, would you have gone for the same technique or would you have gone for a secondary? Because this was a traumatic cataract and you do not know the zonules of the long term, though it's not progressive.
Yeah. So I think a very good question, Ajay. Should we all emulate the same technique, or is it something different that we could do? So first and foremost, Harshal proved very rightly that the snipping of the capsule is very important to atraumatically get a good round capsular access. That was beautifully shown. Something that I would do a little differently, Harshal, is after taking out the nucleus and the CTR, I would like to put it with the hooks in place. With the capsular hooks in place, if the CTR is placed, you have the bag getting supported by the anterior capsule and the CTR goes in quite well. Whereas if the capsular hooks become a little lax, then what can happen that the whole capsular bag is floating up and the PC is also floating up, and then, a little difficulty at times for placing it in. The other thing that I would like to do is placing the intraocular lens inside first before the CTS. The CTS is absolutely the right idea, but once the intraocular lens goes, the CTR goes in, then the IOL goes in, a single piece IOL if I could prefer here. And once it is in place, then you have a voluminous bag, and the CTS, placing the CTS, tying the CTS becomes a little more good, plus the optimal centration of the IOL bag complex is also a little more enhanced. So the very minor points, nothing very great, but these are little things that, I would do a little differently.
Right. So, Partha sir, your all points are well taken. The only thing is, what you said is to remove the capsular hooks before putting CTR. I think you're right that if you feel that, capsular bag is very, very lax and, it will just float like this, of course, you should keep capsular hooks there. But as it was traumatic and I felt it was fairly stable in the rest of the area, that's why I removed it. Otherwise, yes, you can keep it and put a CTR. And yes, of course, put an IOL and then you can put CTS. That's also a good idea.
Yeah, absolutely right, Harshal. I think what Partha pointed out, I think I'll be doing it that way, putting the CTR and then fill the bag totally with high molecular, if possible, high molecular viscoelastic. While putting the CTR, it becomes easier, especially if it is fibrous or if it is lax. I mean, if you got it totally inflated. Again, I would come to Dr. Gaurav. Again, the last point that Ramu made about putting the lens in the sulcus and the multipiece. I mean, that's what I am following for the last few cases, over the years, that instead of putting the single piece in the bag, put a multipiece, and especially the sensor lens. I mean, I have no financial interest. And that lens actually stays very well as compared to other lenses which are there. I mean, that sits very well in the sulcus and the back capsule. Any comment on that?
Yeah, so I agree, Ajoy. That's something which I've been doing for some time as well now, that having the optic inside and doing the capture and have the haptics, and it helps. And I would completely agree with that. But sometimes, especially with these rexes, like what Harshal was showing, it may not be very easy to do a capture. In a healthy capsular bag where the rexis is nice and flexible, you'll be able to capture it well. But in a fibrosed capsule where sometimes, you kind of manipulated and cut and made a rhexis, you may not actually get a meaningful, capsular, an optic capture, but one must definitely try to do that. And second thing I thought was that while Harshit showed everything so beautifully, I would have for the sake of discussion, I'm just putting in, I would have probably done a Hoffman's pocket rather than make for myself, and then whatever works best in your hands. And I also think that, sacrificing the bag in all cases, as we might think is the way to go. I mean, in all these unhealthy capsules may not really be necessary. I would think that 90% of these 80 or 90% of these bags may not dislocate for many years to come. And those that do, if you have a CTR inside, it becomes so easy to salvage them and refixate them to the sclera that I don't know if it's worthwhile. Very bad bags, I would definitely sacrifice completely. But some places where I can salvage the bag, I would still go with a CTR inside or a 3-piece lens for sure, so that just in case they give way. And of course, Gore-Tex probably is the way to go, because it's definitely will last much longer compared to what we were using in the past.
Thank you, Gaurav. I think we move to our next speaker, Arup. Is it Devashes? Thank you, Ashu, for that showing that wonderful surgery.
Thank you so much.
Great, especially the rhexis that you managed.
Yes, our next speaker is Dr. Devashes Dutta. If you can share your screen, please.
So please minimize this one.
Is it visible?
Yeah. The video started already.
Okay. So it is a case of subluxation and everything. But before anything, I pledge my absolute regards to the esteemed teachers in the panel, from which I learned so much. And almost whatever I'm going to show in this particular video has been discussed and shown in this by the esteemed panel. And so without much ado, I go straight away. This is the case of subluxation with a little bit of vitreous prolapse already in the anterior chamber. Is it what it is? Yes. So as there is a subluxation in the beginning and there is vitreous prolapse, it is easier to do a pars plana vitrectomy and place the trochers right at the beginning, because once you enter the anterior chamber and proceed, eyeball becomes a little bit soft and it becomes difficult to place the trochers easily. So because as there is vitreous, I would like to manage the vitreous from the pars plana. So I make the pars plana float right at the beginning. And I also design those Hoffman back pockets. So I strain the anterior vitreous right at the beginning because there is vitreous. So I must know how much of vitreous is coming in. And then I plug it with high molecular weight viscoelastics. And then I use trypan blue in small aliquots. Otherwise, it will escape into the posterior segment and will compromise the red flow thereafter. So carefully staining the anterior capsule by using small aliquots. Now I use a marker and I do some sort of with a cutting port facing towards the optic disc. I do a pars plana vitrectomy as far as I can. And now I fill in with Hilon GV to give support from the posterior, because I've eaten away the vitreous from the posterior part, and now it makes rhexis more easier, because I have a support from behind supporting the lens. Otherwise, it would be even more difficult. And as it is Hilon, it's cohesive, it would be easier to remove in toto after I finish the surgery. Now I do a bimanual, I place the capsular hooks, this MST hooks, and I do a bimanual rotation to make sure that it is free. And as there is so much of it is precariously poised, so I use a MST, this segment CTR right at the beginning, fix it up with iris hooks and place the CTR right at the beginning. Because without the support of this amount, it is difficult to proceed to keep with the phacoemulsification. So then I went in for direct chop and careful phacoemulsification as much as I can. And now somehow I plan to place the multiface lens in the bag. It can jolly well be placed in the sulcus, like everybody said. And now this is the Vortex suture. It is a 7-0 suture. I thread it and then bring it out to the main port. Now I go through the bed of the Hoffman pocket through a 26 gauge needle and feed the ends of the Vortex to the 26 gauge needle, punch it there so that it does not come off when I'm withdrawing it through the bed of the Hoffman's pocket. Similarly is done, same thing is done with the other end of the Vortex suture. The needle which comes with the Vortex suture is difficult to place. And now I titrate and center the bag, a bag with IOL complex, and titrate the knot, centering the bag as much as practicable. Now you can see there's a rexus coming in the middle, so I make it proper. And thereafter I remove the Hilon 5 that I have placed in the behind the capsular bag. So, and I'll check for any vitreous in the anterior chamber. And I prefer to leave a little bit of translucent stomate in the anterior chamber. This is what you get in the postoperative period. Under all your God's grace, things got well.
Thank you, Devashes, for showing us the excellent surgery. I'll ask comment from Dr. Luthra, please.
Thank you, Dr. Paul. And I think a brilliant surgery shown there. All the take-home messages are very, very good. And so it's going to be tough for me to comment. But the one thing which I might think, and it immediately brought back memories of what Dr. Chi Soon Fek has been showing us about her lasso thing so a very elegant way of bringing these Vortex sutures out rather than having the 26 gauge, because you had to actually manipulate the 26 out of the main incision and
yes,
then
it's difficult.
Kind of thread the thing. And so even the incision may get damaged, and bringing it out of a valvular incision of that, it may be a little clumsy to do and difficult, challenging as well for somebody who's not very, very kind of dexterous. So she has shown that nice lasso technique where from the needle there is that small lasso which is projecting, and she just kind of holds onto that those sutures and just pulls them out. Those videos are available. So I think that was one thing where I would probably feel. The other thing was that the trypan blue staining, while you did it again very nicely, and you did mention that you're just doing a very gentle thing. I have seen occasionally, if you go very close to the edge of the lens, the subluxated lens, and some of it goes behind, you tend to lose the glow. So one has to be very cautious about doing it, but then you don't have a choice. If you want to make a capsular excess on an opaque cataract, you definitely need to kind of stain the capsule otherwise, and maybe putting viscoat and making sure in that area that you've kind of ensured a barrier for the dye to go behind just in that area. I would inject viscoat in that area to push the vitreous behind, and then maybe stain, although you kind of have a risk of trypan blue mixing up with the viscoelastic sometimes and make it even more challenging. Other than that, I think everything was to me looked very nicely managed. And yes, maybe in my hands I would have probably delayed the CTR because you were using MST hooks, and MST hooks are expanded at the end. So if you put 3 hooks, are these different hooks? Because I thought
these are the new MST hooks, which do have a very close. It's closed. It does not allow for the passage of the CTR through the eyelets.
No, so I understand. That was not the point I was making. What I was saying was that the bag equator is supported nicely by these MST hooks. So a CTR may not be required right in the beginning when you have a very bulky nucleus in the bag. So putting a CTR, you could sometimes put in the CTR towards like halfway through when the bag starts collapsing and you've removed 1 or 2 of those segments. But it has to be on your comfort zone. So these are few things, and I'm sure others are going to add even more things. But just to make it more interesting for the viewers, these points are worth discussing.
I think you have added whatever needed to be added. So very well summarized. I think if there is no very important message, I will no other message. I will go to the next speaker for the shortage of time, if that is okay with Gaurav. Dr. Ramamurthy and Dr. Partho Vishwas, sir, if you have any very important points to add on, otherwise we'll move to the next.
I think Partho should have would have done an SICS and put a lens. I mean, the first question before we move.
So excellently shown, and I think Vortex is the way to go. The lasso technique that Gaurav mentioned is absolutely appropriate, and I think very well shown video. Nothing much to add.
Oh, fantastic surgery, and I think the absolute take-home points dealing with the weaknesses, the first step and application of pastana, explaining in the anterior chamber, and using Helon in the vitreous cavity to support the lens is I think an excellent step. And we want to remember that.
I'm not hearing.
You're not hearing?
Louder, please. Louder.
Audio is going down.
The audio.
Dr. Ramu.
Is it okay now?
Yes.
Yeah, it's fine. It's better.
Okay, what I was saying was a beautiful surgery and a very important take-home points dealing with the vitreous through the pars plana, but staining in the anterior chamber so that you can actually see the vitreous literally going back. And second thing was filling the anti-vitreous cavity with Helon so that the lens remains supported right through the steps. Important point that came out was that nowadays you have those capsular support which has a hollow opening so that the endocapsular ring has a tendency to slip through that. So that even with the capsular hooks in place, you can fasten the endocapsular ring with confidence. One important point I wanted to make was that whenever I'm faced with a difficult situation like this, I go to a 3-piece lens rather than a 2-piece lens because it's much more amenable to whether you want to place it in the sulcus, the back, if you have a subsequent loss of support on the capsular back. Again, supporting this lens onto the sclera is much better. So obviously the main advantage of single piece lens is it passes through a smaller incision. But when you have a difficult situation like this, switching over to a 3-piece lens gives you a much more versatile way of handling different situations. Otherwise, very well done.
Thank you, sir.
Devashes, it is a nice case. Just I want to mention 2 points. Before tying your CTR segment, if you want to enlarge your rexis, you enlarge the rexis before the time CTR segment, because if you want to enlarge the rexis after tying the segment, it can taut and you can run away. This is the only thing that I want to mention. And another thing, this is a MST Chang modified in MST hook. It's a only small bulb. You're not able to pass the CTR. The previous design of MST hook, you can there's a double flange. You can pass the MST CTR in between the 2 flange. So this is a much safer kind of MST hook. So our next speaker, Ajada, is Dr. Minu.
Yes, Dr. Minu, please.
Yes, sir. Thank you, OSWB for this opportunity. Am I audible and my screen on?
Yeah. You're audible and screen is visible.
So if I had known this before, that these kind of subluxations are there, I would have changed my case. See, these are, and I would like to first of all congratulate Dr. Devashes for showing such a fantastic. This is one of the best subluxated videos I have ever seen. Anyway, we'll go on to this. Although we will add on most of the points have been told, but then see, this is as far as I am concerned, this is a very straightforward looking case for all of you. This is a very straightforward looking case. A 6 mm dilated pupil, an okay grade 2 nucleus, nothing big. But then when we look into the, when I looked into the A scan, so if you look at the lens star reading here, if you see the lens thickness here, the right eye, this patient, this case is the left eye. So 4.9 and 5.81, close to 6 mm lens thickness, and an anterior chamber depth of 2 mm. And this white to white is okay. So this gave me some indication that there is something could be wrong. And then we look at the fundus, you see an epiretinal membrane there. And his endothelial count was okay, relatively okay. So then we asked him again history. He said there is a history of blunt trauma with the hand, a fist, 10 years back. And so we were now dealing with a shallow, very shallow anterior chamber, a thick anteroposteriorly very thick lens, or even a globular kind of lens. Then we looked very carefully, there was subtle phacodonosis. It was not very obvious phacodonosis, but there was subtle phacodonosis. And to add on to that, he was on tamsulosin for his prostate problem. So that's why we saw a 6 millimeter. Now does it? It looked more problematic to me rather than a straightforward looking thing. So to go on to the case itself, it is done under a block, and I just see that for the movement there is no much movement of the lens. So the incisions are precise incisions, and now the first thing I put in is sodium hyaluronate, so that I don't shallow the chamber much and I get maximum space. Now please watch carefully. Touch the lens. It moves left, it moves right, all the way. There is subtle movement here and there, not gross movement. So then the next important thing is to make a very appropriate sized and central capsulorhexis. Central capsulorhexis again is very important. So I start with the needle. I am used to a needle. So I start with the needle through the main incision, then go to the paracentesis, because the chamber was quite shallow and the access was more easy if I go to the opposite side. And so from there also I go slowly, very slowly, and make very small movements, and so that I can control, put more viscoelastic again, and then keep the chamber very well formed and complete a 5 to 5.25 millimeter rhexis. And then the next thing is to do a gentle hydrodissection, but make sure that the wave goes along, and make sure that the lens is mobile, and then start off phaco. So when I am taking out the epinucleus, we can see the movement of the lens. So when this is being see now when I am trenching a little bit, see the movement of the whole lens. So here, see again now, just now. So I am going ahead with very low parameters here. So bottle height adequate enough so that I don't get chamber fluctuation, and adequate power. There is only a grade 2 nucleus here, so I don't need to use too much of power. And the flow rate and the vacuum are lesser on the lower side, so that things are going very, very slowly here. I don't want more damage to happen to what has already happened. So here I go ahead with again the chopping technique, which I am most comfortable with. And here the incisions are not too large not to allow the iris come into this one. The fluctuation under the iris should be minimal, the fluid flow, so that you don't get your pupil down during the surgery. And after chopping, the rotation is gently done. This is a little speeded up video, that's why it's looking a little fast, but things are done very slowly. And then finish off the phaco. This is relatively easy because it's not a very hard cataract. At this point of time, we can see that the rhexis is quite round. But now just see when I am trying to pull the cortex. So this is visco, but see the rhexis margin here. Here this was almost here, and the rhexis margin comes still here. So that means there is lax zonules, especially the anterior zonules. So I don't expect a whole loss of zonules, but diffusely loss of zonules anteriorly, because it is more on to the rhexis margin. So that is when the rhexis margin moves more when you are pulling. And this is not any sticky cortex. People we should not think that the cortex is more sticky. It is not. It is because there is no counter traction of the zonules that the bag also moves along with the cortex. So once that is done, I do, because I am more used to a coaxial one, I use a coaxial IA. Bimanual is also fine. And then once you are close to finishing, see the movement of the rhexis margin here. See, when I hold on to the capsule here, unintentionally, see how much folds I get on the anterior rhexis margin. So after removal, this should be done every time. When you remove irrigation, fill up the anterior chamber and the bag with visco, and then only remove the irrigation. Should not allow the chamber to shallow. And then you can now notice that the shape of the rhexis itself is slightly oval now. So that means there is the zonular weakness, and now my CTR goes in. As we say, delay it as much as possible to facilitate the better aspiration of cortex, because the zonules are weak and you put the CTR and it traps the cortex. And you can avoid that by trying to remove it if possible. And the hooks, the capsule hooks are not required in this case, because it is more subtle and more diffuse all along. And there was equatorial and posterior zonules which were still supporting the bag. And the CTR, I like the manual way of inserting. I go along the paracentesis, and towards the end, using the second instrument to support it, I use a microrhexis forceps to hold it and place it in. Now comes the important point of putting in iris retractor hooks. Because the pupil had come down a little more, I want to see what is happening. What is at the equator? Is there equator of the lens showing up, or where is the center of the rexus? I want to see the rexus margin, and all. The only thing which I can show now, different from what was it, I am placing the 3-piece IOL. I use the Technis lens. It is similar to the sensor. Only thing is it is aspheric. It goes in. I want to see the whole rexus margin when I am placing it in the sulcus, and I am trying to center it in the sulcus first, and then aspirate the visco within the bag. Here again, the flow rate will be very low, and aspirate the visco within the bag. And now I am capturing the optic within the rexus margin. So now once that is placed in the sulcus and captured in the rexus margin, this is quite well centered, and I form the anterior chamber well, and take out the iris hooks, and then most importantly I put in the Vigamox intracameral, the moxifloxacin, to end the case. So pre-op counseling for these kind of patients is very important. Tell them that you may have intra-op complications, and you may be changing the type of lens or the type of surgery, or you may be deferring the IOL placement. And I use for all these cases pre-operative mannitol to shrink the vitreous and reduce the pressure from behind. And I do all of them under block and give adequate massage, not very violent kind of digital massage, continuous soft massage, and make it quite soft. And the incisions, especially because of the possibility of an IFIS in this, the accurate sized incisions and no leak at all, and slightly longer on the corneal sides, and cohesive viscoelastic initially to form the chamber to get enough adequate space for your rexus, and as previously said, dispersive viscoelastic along the undersurface of the iris so that you don't push more fluid. The problem of more fluid going into the vitreous is that you may get positive pressure while you are trying to aspirate the cortex, and you may get a PC rent. The PC may be bulging up when your fluid gets pushed through the zonules into the AVF. And the parameters we told, chopping technique, and iris hooks always kept scanned by. You don't know when this pupil is going to come down. If it is adequate for your phaco, you can continue, but then at any point of time we should be putting in iris retractor hooks, and dispersive as I told, and always fluid OVD exchange while taking out the irrigation, and capsular bag stabilizing devices when at the appropriate time, and adequately visualize the bag and place the IOL like we saw here. Thank you very much.
Thank you, Dr. Minu. I think that was a wonderful way of a teaching video, just like a teacher on the Teacher's Day. They're specifically looking for those subtle signs in the biometry. I think how many of us would have missed it, especially looking at the video. Any comment I would like from the expert jury, especially the way he managed his lens and the way time when he put his CPR and the lens in the sulcus idea. Anything on the biometry? Yes? Dr. Ramu, Dr. Patra, and Dr. Gaurav, please.
I can only repeat what you said. There was so much of subretinal hemorrhage. So obviously,
your voice is coming very. Okay. Yeah, audio. Yeah.
Can you hear me now?
Yes.
Yes, better.
No, I can reiterate only what you said in the sense that Minu suspected a subluxated lens only because of the biometry. So most of us look at biometry only for the intraocular lens power. That's something which is written there. So a good look at that's the reason he had given a peripalpal block and prepared the patient for this reasonably complicated surgery. I think all the steps that he did was excellent, and what we had already discussed. And it was just a good closure to what we had all earlier reiterated.
Any comment, partner?
No, agree. I mean, excellent video. A lot of learning points. Very nicely done. Very nicely done.
Yeah, beautifully done case. The only thing which I can add, because, for the sake of discussion, I would have used a rexus marker to get the rexus size perfect, and, making sure, because you're planning to capture your IOL, and you want to be sure that your rexus is neither too big nor too small. So putting that indentation rexus marker is just like a 1 second's job, and it gives you a perfectly sized, perfectly shaped rexus, and makes your job. Otherwise, everything was spotless. And yes, femto would have been, if I'm suspecting subluxation today, I pretty much switch to a flax, but then that's something which only if you have flax, you'll do it. Otherwise, you did it so well. Great job.
Thank you. Thank you, Minu. I think that was a wonderful gift for us on the Teacher's Day. Yes. Arup, we move to the next speaker.
our next speaker is Dr. Love Kachwe. His topic is Campbelling tear.
Is my screen visible?
Yes. No, visible. Yes, yes, visible.
So I'll be dealing with 4 videos of a pre-existing PC tear. And first one of it is posterior lenticonus in pediatric cataract. And as you can see here that after the initial rhexis, no hydro procedure was done. And we started aspirating the cortex from the periphery first and then going to the center. So the main aim is the least vitreous disturbance till the cortical aspiration has been done, and even after that. That will ensure this, and we have to be very careful that it doesn't fall back into the vitreous cavity. So sudden decompression of the anterior chamber should be avoided. And then, as you can see, a dry vitrectomy is being done first to remove the whatever vitreous is there in the bag, and then inflate and implant the IOL possibly in the bag if possible. And here you can see that we were successful in implanting the bag. And that is exactly the point Dr. Ramamurthy had mentioned earlier. I mainly prefer 3-piece lenses in these cases so that I have the flexibility of implanting the lens either in the bag or a sulcus. Now here in the post-traumatic case, you can see this line. So on the table itself, we should be prepared for a pre-existing PC defect, and same approach is used. The peripheral cortex is aspirated first, and it's a young patient, so no phaco is involved, just the cortical aspiration, and the mistake after this sudden decompression of the anterior chamber. And the second mistake now is implanting the IOL without removing the vitreous from the anterior chamber. So as you can see, the IOL is being rotated, but it's not going in the bag. And then you realized that there is vitreous in the anterior chamber. So what we have to do is go with the cutter. And this was a risky step because this caused some vitreous traction. So once and another thing that can be done here was triamcinolone can be used so that we are able to actually mark the vitreous in the anterior chamber. But we didn't use that. And once the vitrectomy was complete, the lens very well went into the sulcus and is very well centered after that. So along with the, I'm also commenting on the mistakes that have been done in these surgeries so that for a better understanding. Now in adult cataract, most of us face the posterior polar cataracts, and with a slightly 5.5 to 6 millimeter rhexis and only hydrodelineation. As you can see the golden ring, and this one is a soft cataract, so the whole nucleus comes out. And again, the key, we all have been dealing with subluxation, so this is a slightly different topic. And the key again here is do not decompress the anterior chamber suddenly. So here first viscoelastic was pushed, and then I moved out the phaco tip. And during cortical aspiration, all starting from periphery and then to center. And posterior polar cataract, if you are lucky, it may not give way, but if it is giving way, it is not our mistake. That is the character of the cataract. And a gentle cortical aspiration is done. And lens is placed in the bag. And as you can see, instead of doing the viscoelastic, we can just wash away the viscoelastic in the anterior chamber. And this is a slightly smaller pupil with a grade 3 cataract. And again, this point was also discussed. We can continue without iris hook till the point we are able to do it properly and the visualization is proper. As you can see, there was no hydrodissection done, just the spatula has been swept behind the rhexis margin. and small pieces, small pieces of the nucleus is removed, and phaco is complete. Still the posterior capsule is intact, and a large plaque can be seen at the posterior capsule. Sudden decompression is avoided, and cortical aspiration is done, and that is where the pupil is decreasing in size and the cortex is very sticky. So better not to take any chance. The iris hooks are used, and cortical aspiration is done. While doing the cortical aspiration, the posterior PC tear is identified, a linear tear is there, but luckily the vitreous has not got disturbed. And in this case, since it is a linear tear, if we implant the lens in the bag, the chances of lens getting unstable is there. So a 3-piece lens was placed in the sulcus. And if there is no vitreous disturbance, we need not do a vitrectomy in such cases. And at the end of it, you can see a good round pupil. And again, with to avoid vitreous disturbances, we just washed away the cortical matter. Thank you so much. Unmute, sir.
Unmute. Arup, unmute.
Thank you, Dr. Lal. It's a wonderful presentation, and you are basically focused on the all kind of pre-existing PCR or capsule adhesions, or the potential to give away the posterior capsule. So I want to know the jury to highlight how to deal this type of cases, especially 2 points. One is PPC with hard cataract, the tips for the PPC with the hard cataract, and how to manage thick epinucleus bowel in case of PPC. Whenever you remove the nucleus part, but even then in PPC, you have a large, thick ball of epinucleus, and it's very difficult to remove and very difficult to rotate. In that case, in
last
PPC,
case was like that.
Yeah. How do you manage these type of cases? Over to Dr. Ramamurthy, Dr. Partha, and Dr. Luthra. And
nice.
Obviously, Dr. Ajay Pal also. He's an experienced surgeon. You want to listen from Dr. Paul.
Very nice set of videos, Lal. And finally,
sir, your voice is.
I don't know.
Yeah.
Can you hear me now?
Yeah.
Yes, sir.
Very nice set of videos, Lal. And thank God that we finally got some capsular bags which are fixed and not dangling. And just a few points in which I would have thought differently is that one is that in all these cases, I would have done the peripheral bar. Whenever I suspect that there could be a problem, I go for a peripheral bar. And an anterior segment OCT, either what is available in your laser system, or otherwise preoperatively you do that so that you are prepared for dealing with it. And as far as the capsular rhexis size is concerned, I saw that you are tuned in 5.5 millimeters. I definitely go for a 5 millimeter. Even on the laser platform, even for my normal cases, I go for 5 millimeter because I always find that it retracts a little bit. And I want a slightly smaller rhexis so that I'm able to create a good optic capture. One thing is that even in your initial 2 cases, though you did mention it, I think in today's world, not using translunar state is not pardonable. And I think I always thought if you have a round pupil and a round rhexis, there's no vitreous in the AC. Your colleague Partha has taught me not to believe that. That's what he in his court martial. And even at the end of the surgery, I use a little bit of diluted tricot to make sure that everything has come out. And as regards Arup's questions, whenever there's been an incident in the first day, sometimes with a hard total cataract, you can't even see the PPC. If the surgery has been done well, if there is an optic capture, I always think that there could be a posterior polar capsular defect in the second eye if there has been a capsular tear in the first eye. So I would appropriately deal with it. And if they not really rotating the lenses, not doing hydrodissection. And in case there is a large ball, you must understand that once the lens material has been largely removed and the lens has been debulked, then this is the time if you have been allowed with, there is some amount of lens material, whether it's epinucleus or cortex, and you can go ahead and do a hydro dissection or even a visco dissection, because no longer the capsular bag is under stress, or so it's not going to give way that easily. So going ahead and doing a good visco dissection or hydro dissection will pull in all the cortical matter towards more centrally, and you can aspirate this quite easily. These are just some tips that I wanted to add, but otherwise very well done.
So,
It's 7 o'clock.
Yeah. So apart from the comments that Sir has made already, so about the pediatric cataract, the lenticonus, the posterior lenticonus, where you have a deficiency in the capsule already. So here again, as different from an adult cataract, where in the adult cataract, you are actually able to take time and see in the slit lamp pre-operatively that this is what we have with a posterior polar cataract or otherwise. But in a child's case, where the child will not be so cooperative and you might definitely miss a posterior lenticonus, it is on the table examination, I think, and I'm sure you would agree, that it is very important to see that part of the cataract, especially if it is a cataract which is grade 2 or grade 3, and it's obviously it's a soft cataract in most of these cases, but to visualize that part of the lens of the posterior capsule and to ascertain whether there could be a possibility of a dehiscence in these cases. So that is one point I wanted to highlight, which I'm sure you would also agree to. The second thing is, when the dehiscence occurs in the posterior capsule, and with a very, very elastic posterior capsule which is dehisced. So you placed a intraocular lens, a 3-piece intraocular lens, and actually rotated it into the bag between the ruptured posterior capsule and the anterior capsule. Very, very difficult, I'm sure, and it at times, it might slip, and especially if the vitreous has prolapsed between the torn posterior capsule and the anterior capsule, then it becomes quite messy. The only thing that I think would be maybe a little deviation from what you did is if we can place in viscoelastic, high molecular viscoelastic, separating the torn posterior capsule from the anterior capsule, and then place it under direct visualization, a single piece which just goes in and does not need to have rotated. So that I think means could be done. And I mean, these are both ways which can be done. Of course, the 3-piece works well if you have lost the bag, and if you have to place it into the sulcus, then the 3-piece is definitely the better choice, with a capture, of course, optic capture.
I think we've already heard almost everything, but I would just like to reiterate that, suspecting that there may be a pre-existing PC rent is probably the most important thing to preempt complications. So, post-vitrectomized eyes, injection eyes, and, pediatric cataracts, I always kind of focus on the anterior capsule. And then if there is visualization of the posterior capsule through the cataract, I will, go deeper on a deeper plane and try to examine, these intumescents and the posterior polar cataracts and pediatric cataracts, and try to see if, the anterior vitreous is showing any debris. Sometimes you'll see telltale signs of small debris floating on the anterior vitreous phase, and that can warn you that there may be a pre-existing dehiscence. And as far as Arup said about posterior polar cataracts with pre-existing PC rents, they are really challenging. So you want to actually leave an epinuclear shell by doing hydrodelineation, and you can actually, I've done quite a few of these pre-existing PC rents, PC defects, posterior polar cataracts. You can do them quite well by removing the nucleus and leaving that shell behind. And once you've gone through that, then you can gently kind of, go into the equator and piecemeal, like eat in all 360 degrees, remove the kind of the frill. And then you're left behind with that small area where it is attached, potentially attached to the edges of the PC rent, like a small chunk of about 3-4 millimeters, which is still attached to the edges of the pre-existing PC rent. And then you have to do a visco flotation, because if you try to do it, in any other way, like holding it and trying to aspirate it, or even using hydroflotation, sometimes you'll end up causing the fluid to go into the vitreous cavity. So a visco flotation of that small chunk from the side, it kind of lifts off, and then you can just remove it and then put a lens and capture it. That's how I would probably handle these epinuclear shells.
By the way, any PCR we jury get is pre-existent. We never do it.
Absolutely, sir. That goes without saying.
Thank you, Gaurav. And we move to our last speaker and the showstopper of this session, Dr. Deepak Megu. Over to the Deepak.
Thank you, sir. Thank you for the opportunity.
The best for the last.
Highest resolution video that we'll get to see today. I think.
PPT video, I'm sure, Deepak.
Sir, thank you for the opportunity, and it's a pleasure to present in front of all my teachers whom I have learned a lot over the years. So it is going to be a happy Teachers' Day. It's an occasion. So I'll be just sharing my way of approaching a case wherein we have a rhexis which has gone off. And disclaimer first, obviously, the decision to continue with SICS or phaco would purely depend upon the surgeon's experience, skill level, and the backup which he has at his institute. So with that, I think I'll just play. It has got an audio. Please let me know whether the audio is there or not. Okay.
No, we can't hear the audio, Deepak.
Just a second.
This 65-year-old man with an intermittent cataract and the rhexis has run off to the equator. What to do once we have it? Well, I have decided to continue with phacoemulsification in this case. The nucleus is not soft, but it's about grade 3 and does not appear to be very hard. I think it's manageable. The pupil is extremely well dilated and the cornea is quite clear, so visibility is not an issue. Well, I have been in this situation many times in the past and I am backing myself to meet the challenge in the event of any intraoperative difficulty. And let's see how things go. The goal is to prevent the tear from extending onto the posterior capsule. The first thing I need to do is to enlarge the capsular opening. But before I do that, I need to decompress the bag. Carefully and slowly, the swollen cortex is gently aspirated from underneath the anterocapsular flaps. Before switching hands, OVD is injected to prevent shallowing of the antechamber. The OVD is injected above the anterocapsule. If we inject here, that is in the opening below the anterocapsule, the chances are the tear can extend posterior to the equator. Using a micro scissors, a tangential cut is given to the anterocapsule and I'm using a forceps to trim the capsule. The same procedure is repeated on the other side. I didn't want to make a very big opening, but this is slightly smaller than what I would have liked. I have chosen to perform stop and chop technique for nucleus management in this case. While sculpting, I'm very careful that I don't exert any stress on the bag. I'm using good amount of phaco energy to ensure that I don't push at the nucleus. I'm also aware that I cannot rotate the nucleus before creating some space. I thought the trench was deep enough and I'm trying to do lateral separation carefully. The posterior plate in the inferior half is separated, but the subincisional half of the posterior plate is not separated. I am skeptical to use any more force. I thought I will chop and take out one piece which would create more space in the bag and then would be less stressful in the bag during further nucleus manipulation. And then go and emulsify the two free pieces. Each of these pieces are pulled out of the bag and emulsified in the supracapsular region. The chamber is refilled with OVD. Since the bag is empty, the nucleus rotation is less stressful to the bag now. The heminucleus is then chopped into two fragments. Then one of the fragment is pulled out of the bag. Now in this situation, I need to be extremely careful not to have lens chatter because the endothelium is quite close here. So reducing the amount of lens chatter is going to be invaluable in minimizing the endothelial trauma. The remaining fragment is emulsified in a controlled manner. There is no cortex to aspirate. The bag is formed with OVD and the lens is implanted. So to summarize, a discontinuous rhexis creates a weak area in the anterocapsular opening and it carries a risk of a wraparound tear extending to the posterior capsule during nucleus manipulation and carries a high risk of nucleus dropping into the vitreous. Now, if I decide to continue with phaco, here are the 7 principles I would like to follow. The first thing I would like to do always is to enlarge the other quadrant of the rhexis, especially if the capsular opening is very small to begin with. By enlarging the capsular opening, it will ensure lesser stress on the bag during nucleus manipulation, especially during division of the nucleus. Typically, I avoid hydrodissection and minimize nucleus rotation in eyes which have a discontinuous rhexis. The third most important principle is to ensure that the chamber equilibrium is maintained at every moment of the surgery, because sudden shallowing or sudden deepening of the chamber is going to extend the torn edge of the anterior capsule beyond the equator and into the posterior capsule. While performing phacoemulsification, I ensure that I keep a close watch on the tone flap at every moment of the surgery. If the flap is mobile, fluttering and everted, then it's all good. This is the flap motility sign. During nucleus chopping maneuvers, lateral separation has to be very gentle to minimize any stress on the tone edge of the anterior capsule. After the first chop is done and the first fragment is created, invariably I pull it out of the bag and emulsify it first. This helps in creating space within the bag, which ensures that there is lesser stress on the weak capsular margin. And finally, the fragment emulsification is done in the anterior chamber above the anterocapsular plane. Hence, it becomes mandatory for us to protect the endothelium by using adequate amount of good dispersive OVD. So these are the 7 principles which I try to follow.
That was it. Thank you so much for the opportunity.
So absolutely flawless surgery, flawless demonstration, and flawless recording system. Over to juries, whether they can find any flaws. Dr. Ramamurthy sir, please.
Wonderful surgery, Gaurav, Deepak. I mean, nothing else was expected of you. It's always a pleasure to watch your surgeries. My one question, because you did everything right, one question is that in the case which you showed, the run of the Argentinian flag sign was 90 degrees to the where most of your maneuvering was, where you get trenched and where you split the nucleus. Supposing the tear had occurred along that same axis where most of your maneuvers are going to be happening, would your approach been any different?
Not much, sir, actually, because we can't change the site when during the surgery, in between if it happens. But I've had situations where the rhexis has gone parallel to my incision as well. So the principles would still remain the same, I would guess. Not much of a difference.
Sometimes, when you are especially doing a
lateral separation
and you are doing a lateral separation, that imposes a certain amount of strain along the. In these cases, what I do is to rotate the nucleus in the opposite to the axis in which there is a runoff. Otherwise, as you said, everything else is nearly the same as what you would have done. And of course, you had total cataracts, hard cataracts. But many of these cases, sometimes intumescent cataracts, the cataract is quite soft. So the first thing that I do is to, after fashioning out the rhexis, to prolapse out the entire nucleus into the anterior chamber and use adequate amount of dispersive viscoelastic. When you're doing most of your phaco and maneuvers in the anterior chamber, there's less of a strain on the capsular bag and less chances of it extending. And the tip about always injecting the viscoelastic, especially a heavy molecular weight viscoelastic, on top of the capsule and not into the lens bag is extremely important. Sometimes you have a extension occurring just because you are wrongly injected into the bag. Otherwise, everything was beautifully done.
Thank you, sir.
So Deepak, I think we have not had any court-martial for very long time, So I'm just itching. So anyway, I'll temper it down. But what I would say is, when you were doing your stop and chop, I would firstly say that, stop and chop might not be the right one in an open bag. The bag is open, the anterior capsule is open. So in stop and chop, because you're going to do the separation as much as possible to get the crack. So here, I would suggest that if we do a direct chop, and then the stress on the zonule is definitely much less. However, these zonules definitely do hold and come in. So that was one point that I would like to say. The second point is, and in these bulky nucleus with a thick posterior plate, where the separation of that posterior plate really would definitely be more stress on the zonule. Here, what I would do is, or what I usually do is, take a very small pie to debulk the nucleus first, and then take another small pie, again with a direct chop, to gradually debulk. And then once it is debulked, then take the nucleus up and out of the capsule, and then do the rest of the capsule, the nucleus management. So just these two small things that I would like to add on to this.
Partha, you took away both my points.
Yeah.
I was going to say exactly the two things, but I have something additional to mention there. But so I think, I would probably not do a stop and chop, as you said, because, once you've done this, the trench, and then you are doing a lateral separation, trying to crack the posterior plate, there'll be too much of a separation. But on the other hand, I think that doing the trench is definitely not a bad idea, because you're creating more space, you're debulking the nucleus. But after the trench, I would rather not crack it the way we would do with a stop and chop. I would go to the end of the trench and chop, and create a small peripheral crack in that, because that would have debulked my nucleus. I would not be separating the posterior plate at that time, as you have suggested, Partha. I would initially create one crack, using a chop right in the periphery, remove a small chunk with a second chop, and then, I would have debulked the nucleus, and I would have removed a small pie. And that way, you could, and so direct chop is definitely the way to go in these cases. And the lateral separation of the posterior plate, is definitely not recommended right in the beginning. Second thing I would think is that I love to do with these very hard cataracts, whenever I have a broken rhexis or a compromised bag or something, I like to do the woodpecker technique, because that way, in a hard cataract, you can embed both the instruments, your phaco tip and then also your chopper. And then rather than trying to do a very strong chop where you're using high forces in a hard cataract, you just give pressure with the chopper and do a burst of phaco, or maybe 2-3 small bursts of phaco with the phaco handpiece. The chop gets done very, very nicely without any forces being used, and that way your bag is not compromised and you're not applying any pressures. So these two things can help, in compromised rhexis, broken rhexis, and compromised bags where you're dealing with a very hard cataract. The chopping becomes very, very easy with those. These are two pearls which I thought, but I'm always amazed by his quality of videos, how nicely they are done, and how he's able to explain, flawless videos, and really enjoy them. And he was actually streaming from YouTube. He wasn't showing from his computer. So that means that you can imagine, after compression and, with YouTube quality videos, they would have been, D kind of, and then we could still see it so well. Amazing.
Can I have a comment? Yeah, Deepak. Just I've seen the machine parameters. There would be always two schools of thought, especially in the Argentinian flag sign, where the bag is both ways, it has gone. You are using an IOP of 65, 70, that's what I was seeing. The risk as against doing a moderate IOP, maybe 30, 40, versus using a high IOP. What are your thoughts of putting the bottle height down and up, and especially when you have an Argentinian, as against, open rhexis in one side versus two sides?
Yeah, that's a very good point. Excellent point, which I would like to say. But yeah, it's important not to pressurize the chamber, which already it is. I think maintaining the equilibrium, I feel, is more important rather than working on the sides. Sometimes I get micro shallowing of the antechamber when the pressure is brought down to 35-40, even in my Centurion. So that is really uncomfortable for me, even in such situations. So I didn't want to take any chance of that micro shallowing of the chamber. That happens whenever you lose the grip on the nucleus suddenly. You get those momentary shallowing. So that is the reason why I prefer to work at 60 IOP in these situations. And coming back to the previous point of chop versus this, I think the stress is predominantly when we laterally separate. Even when we do a direct chop, the stress is going to be when we laterally separate. So one way to minimize, if you have already had a debulking of the nucleus done to about 90%, then the stress, the pressure required to lateral separate is very less. And because this torsion energy is there, we can really eat away the nucleus very efficiently without cutting anything. So if you use 90% and go in, you can go in deep and do 90% of the debulking without anything. Another problem with the Alcon machines is the tip is so narrow. When you do direct chops in such very bulky nucleus, you know that there is always a risk of the nucleus getting torqued, especially because the bore is very small in this. So sometimes the machine has an advantage. So that's the reason why I tend to use it, because we can get a flawless cutting here without anything. So that is unique for this machine, which is not possible with the longitudinal machines. So you keep 90% energy in a torsional with a balanced tip. So that cuts very efficiently. And once if you cut 90%, the amount of energy required to separate is very less. So that is one way of looking at it. So that was my thought process in that. Anyway, thank you so much for all your advice and comments.
I would absolutely agree with what Deepak said. One thing is in the stop and chop technique, even in these cases, as far as you have shaved the nucleus down to almost just its posterior plate and gone down to 90-95% and rotate the nucleus at 90 degrees to the direction of the runoff of the rexus, and then very gently, very gently separate it so that it gives way very easily. I think you are not stressing the capsular back too much. Of course, doing a direct chop would also be a good technique. I use 30 millimeters routinely with my Centurion, and I find that it works reasonably well even in these difficult situations. But of course, sometimes when the chamber is tending to shallow, then raising it up to 60 millimeters or maybe a good idea. But and the final point is that I always believe that having the rexus run off in more than one direction is safer than a rexus running off only in one axis. So if you have a Argentinian flag sign and you have it perpendicular to each other, I believe that this rexus has a lesser tendency to wrap around and involve the posterior capsule than a rexus which has run off only in one clock hour.
Arup, I think before we wrap up, there's a question in the chat box. One of our ex-presidents has put, I think it's a white cataract, about white cataract, the new technique which has been shown, the seam needle technique. I mean, we have all various, double rexes and puncturing, as Sugato said. Any comment? I think the jury would comment on that. Dr. Gaurav or Dr. Ramamurthy, because that's one of our ex-presidents asking. I mean, the needle which goes in, and then the bevel tip which avoids.
Yes. Do you have any experience that Dr. Rajendra Prasad's needle
technique,
the anti-capsule?
Oh,
white cataract?
Yeah.
I've heard about it, but I've not done it. But I don't think it's right to comment. I mean, without really knowing fully about it.
Okay.
As we make a puncture, if it's a round puncture, see, I have accidentally made this kind of round punctures beyond the rexus margin when I use a very sharp chopper, and I realize it after this one is finished. Actually, that edge is very, very stable. Those edges that is the advantage he takes with the rounded kind of needle tip which he makes punctures on. So those intact round margins are quite stable. That is one point which I have noted.
That's the point to be made. Thank you.
So, on behalf of West Bengal Ophthalmic Society, I thank you, all of you. Take your time in this Sunday evening. Thank you, everyone, for joining us.
Thank you. Thank you so much, sir.
Thank you so much.
Thanks, Arup, and thanks, Ajoy, and the whole OSWB team and all the presenters who did such a great job.
Physically in IRSI.
Yes. Hope.
Hopefully.
Yes, December. We are looking
December,
forward to
yes.
December.
Yeah, I hope we can all meet in December. That will be really nice, and hoping to see all of you soon.
Yes.
At some meeting.
What Harshul, after ophthalmology?
So Gaurav, you are extending the invitation on behalf of IRSI?
Absolutely. We've been talking on this last couple of days and hoping that December we'll still have a physical meeting possible as things look right now, and that'll probably be our first big physical meeting. It should be nice.
Before Partha goes cracking in February.
No,
So
I know.
You would
Partha
rather
is getting up.
see it happen. Okay. Wonderful,
Thank you so
wonderful.
much. Thank you all, and
Thank you.
wonderful evening.
Thank you very much.
Thank you.
Very nice. Thank you, everybody.
The only thing, our master blaster did not have his day. Our master blaster kept quiet and the others were blasting. Arup Bhaumik, master blaster.
But he organized the program so well.
Yes, sir. This is.
Thank you very much. Suhas sir, Thank you.
Suhas sir was there throughout. Yes.
Teacher of all teachers.
Thank you.
Yes.
Teachers
We all learned from you on this day.
I know we've learned so much from Suhas sir that it's like I've learned amazing amount of stuff from Suhas sir. There's no doubt about it.
I told Suhas sir that he is my Dronacharya. In 2000 when we started FECO, there were no YouTube or videos available anywhere. Only one Sion CD was there.
Yes.
Suhas sir had 4 or 5 videos in that. I remember white cataract, brown cataract, different.
Brown cataract.
Yeah.
I had those CDs
so many times and learned a lot from him.
I know.
Thank you so much.
Those
Suhas
videos.
sir. Yeah.
I visited him in
used to operate
99.
in the
That's why
ortholy machine.
got to know so many tips. I was there with him for around 7 days. PPC, how to manage. I mean, those days, the concept of PPC was not there. Here was a person who was teaching us the concept of PPC.
And the best part is we keep learning today. I mean, every time that I attend, I always look forward to Dr. Suhas's presentations because I always pick up at least 2-3 new pearls from them. Even today, I would pick up some new things every time. Yes.
Thank you so much. Thank you so much.
Thank you, sir. Thank you.
Thank you, sir.
Thank you. Thank you, sir.
Thanks, everyone.
Thank you.
Happy Teachers Day to everybody.
Let's have a photograph.
Yes, Harshal, you do the. Harshal can do the honors, huh?
No. People have gone. No
Okay.
problem. We'll take from live
Yes.
recording. Yes.
Arup
Thanks
will
a
call.
lot, Arup.
Good night,
Ajay.
everybody.
Bye,
Thank
Dr.
you, sir.
Bindu.
Thank you.
Bye.
Bye.